All right, good. Thanks for recognizing that signal to sit down. My name is Bruce McLeod. I'm one of the track chairs here in Wellness. And we've got a number of physicians here. We're going to keep it very brief. All the introductions will be very short, just names, because I don't really care if you think if they're professor or this or that. So here's our agenda for today. We're going to invite Jonathan Fowles up here, the only one of us not an emergency physician, but a doctor in his own right with his PhD and fascinating speaker. And then we have a number of other short talks going on, especially mine. And then we're going to have a panel discussion at the end. And I think the fact that you're all here, I'm hoping you all have your own pearl of what wellness is about or how to get through shift work or whatever it is, all right? And if you could, at the end, 15-second, 30-second pearl, take melatonin for night shifts, don't take melatonin for night shifts, something like that. We'd like to have that kind of discussion. So all the emerged physicians have no conflicts of interest, so there's just a general disclosure. So just like to introduce Jonathan Fowles. Jonathan is a professor at Acadia University outside of town, lives around the corner from me. The last time I had him speak, he was scheduled for 45 minutes. He spoke for an hour and a half. No one left, no one complained. So he's going to incorporate exercise into medicine as a daily practice, but also as a personal information in its own right. So, Jonathan.
Thanks very much, Bruce. I'm very happy to be here, just down the 102 or 101 from the Valley. So, my disclosures: I am the chair of Exercises Medicine Canada, the National Advisory Council, and I've had some grants from Steps Count and various speaker fees from different organizations, and most of my work has been supported by the philanthropic organization, the Lawson Foundation, which has supported the dissemination of information on exercise. So today, I'm very honored to be kind of get way more time than everybody else on this topic, but the hope here is to discuss some of the health benefits and safety of adopting regular exercise for both you and your patients, to use the physical activity vital sign as part of clinic visits, and provide approaches to successful and brief exercise prescriptions. So in the last probably 3 years, I've probably done 35 or 40 different workshops and probably 35 or 40 different invited presentations in healthcare, helping to counsel physicians and other allied health professionals about physical activity, the evidence, and how to incorporate it into daily practice. And so this one is, I understand emergency physician and the emergency department is a little bit of a different area than primary care, for example, but hopefully we'll be able to address that. So why should you as an emergency physician talk about exercise with your patients? Emergency departments are providing increasingly higher percentages of primary care for an aging, unfit population. And in Nova Scotia, we're at the front edge of the wedge of the aging unfit population, let me tell you. And so there's many presenting conditions in emergency departments in addition to accidents that can be related to chronic disease. So the World Health Organization identifies that 80% of chronic disease is related to common risk factors such as smoking, physical inactivity, diet, body weight, and stress. And so many of the presenting conditions, and the top ones being COPD, chest pain, low back pain, mental health issues, do and can be attributed to kind of chronic disease origins and the precipitating factors that are related to that. Now, having said that, physical activity and cardiorespiratory fitness, for example, are significant markers of mortality and morbidity and ill health. And there's accumulating evidence in this area more and more of how much we move and how fit we are really determines our progression in these different diseases. And for example, one of the things with this is that as a first-line treatment in just about any of these conditions, physical activity or exercise is recommended as a first-line evidence-based treatment. And take the issue of low back pain, for example. The current low back pain management guidelines recommend the maintenance of physical activity as a first-line treatment. That's the best evidence. That's the number one thing that we should do, is recommend to remain as active as possible and to limit the use of, for example, opioid medications for specific examples only when necessary. And yet an evaluation of emergency departments in the US, 70% of people presenting with low back pain in emergency departments were given opioids, and only 12% were given a recommendation to exercise. So there's a difference of how the guideline recommendations based on evidence might not necessarily be practiced. Now, having said that, I have presented at an emergency department with significant low back pain due to a spondylolisthesis, and I was given an opioid by the end of that because I could not move. So I understand that there's certain individual circumstances where you do have to use your judgment. Now, having said that, I was also recommended to have bed rest, which is probably the worst thing you can do for chronic low back pain. So to dive into a little bit of the evidence here of the accumulating story around physical activity and exercise and why it's so important for our health, is that there is numerous studies showing a direct effect of how much we move on the prevalence and incidence of these different conditions. So everything from hypertension, diabetes, cardiovascular disease, cancer, Alzheimer's, low back pain, you name it. There are 34 different conditions where there's a direct link between the amount of physical activity and or measured fitness and the incidence in these conditions. And for example, reduced mortality anywhere from 31 to 65%. And that's where the first line there in the green is the expected reduction if you meet guidelines. So the guidelines are 150 minutes of moderate to vigorous physical activity per week. But if you do more than that and increase your fitness, you can realize the second number. So that's kind of the range, that if you're moving a bit, you're getting some help. And more recent evidence, and this evidence is basically based on self-report, but more recent evidence that even just came out last year is showing that directly measured physical activity, because if you ask Canadians, do you meet guidelines, about 52% of Canadians will say, oh yeah, sure. But when you directly measure them with an accelerometer, it's about 18 or 19% actually meet guidelines at a moderate intensity for sufficient duration. So the relationship to health outcomes is even stronger when you objectively measure. So this is the guideline recommendations of 150 minutes right here, about 30 minutes a day, most days a week, and you get about a 30% reduction in premature mortality. So this is hazard ratio for mortality. And if you look at this line, it basically is every 10 minutes is about a 10% reduction in premature mortality, all the way down to 75 minutes a day is about a 75% reduction. And this one was the first database that has had the objective measurement with a cohort that is, over 7 years with 5,000 people from the NHANES database. So very powerful dose response effects that plateau at kind of genetic areas there around 75 to 80%. Yeah?
Just to clarify, I mean, it's the definition of exercise. So I'm talking to a patient and they say definition of vigorous exercise. Can you just define?
I have that in a slide in a second. Yeah, no worries. Yeah, I will definitely cover that. So the take-home message here is that we have guidelines of this 150 minutes or 30 minutes, but our new evidence is basically saying that any minute on this line is a positive minute. So whether you're doing 30 minutes, well, 30 minutes is better than 20, but 20 is better than 10, and 10 is better than 0. So the key take-home message here for any patient is that the more you move, the better your health will be. So if you're moving none, getting off the couch and doing a lap around the house is going to benefit your health more positively than continuing to be sedentary on the couch. Having said that, there's also this guideline in our current guidelines that say do it in bouts of 10 minutes or more. Has anybody ever heard that one? That you got to do it 10 minutes at a time? Well, our new evidence based on accelerometer is also putting that one to bed as well. That if we go from moving not at all to the next quartile of physical activity right in here, that whether you move a minute at a time, 5 minutes at a time, or 10 minutes at a time, it doesn't matter. As long as you get out of that low group, you're reducing your hazard ratio for mortality by 55%. So the take-home message there is any way to get out of the lowest physical activity group impacts your health. Whether you do it a minute at a time, 2 minutes at a time, 5 minutes, 10 minutes, 30 minutes, doesn't matter. So those are two very good messages from a counseling perspective and a brief counseling that the more you move, the better off you will be. Now, this also relates to that evidence that I was showing before, that cardiorespiratory fitness is one of the best predictors of mortality and morbidity of any marker. And that when we combine it with the percentage of Canadians that have that risk factor of low cardiorespiratory fitness, and we've done the Canadian Health Measure Survey where we've tested the fitness levels of 5,500 Canadians and compared them to 30 years ago, and fitness levels of Canadians have fallen by 25 to 30% over the last 30 years. Objectively measured fitness. And that's because we are moving much less than we were 30 years ago. So when you combine that 80% of Canadians have this risk factor of not moving enough, combined with the magnitude of that risk factor, low cardiorespiratory fitness is one of the most significant health problems of our current society. More so when you talk about attributable fractions of risk for mortality, more significant than obesity, smoking, hypertension, cholesterol, or diabetes. So let that sink in for a second. It is a huge thing, and we definitely do not move as much as we used to. So one of the, being in an emergency department, one of the things that people present with is chest pain, maybe related to some physical exertion. And the first snowfall of the year is usually a precipitant to vigorous exercise that's done for people with underlying, cardiovascular issue that may be precipitated by vigorous exercise. So many people, even if somebody dies of a heart attack in the Boston Marathon 3 years ago, everybody still remembers it. And to address that, the actual risks of exercise are pretty rare. When you talk about 1 per 1.5 million hours of vigorous exercise in healthy men, or 3 million participant hours at YMCAs, even in individuals at high risk of cardiovascular disease, the incident rate is about 1 per 100,000 hours of vigorous exercise in cardiac and diabetes patients doing vigorous exercise. So the event risk is 0.00001% there. So it doesn't happen a lot. But when it does, everybody hears about it, and that's why we don't hear about the 700 people that die from a heart attack on Super Bowl Sunday while eating chips and wings and drinking 12 beer. Now, having said that, the risk for a sedentary individual doing vigorous exercise does elevate quite dramatically. And for somebody who's sedentary that might have underlying chronic disease, the risk doing vigorous exercise does increase quite dramatically, up above 100-fold, relative to them just sitting there. However, the more that we move, the more that risk goes down. And it reduces, if I do one bout of vigorous exercise per week, it reduces that risk by 5-fold. If I exercise regularly 5 times a week, that risk of the bout of vigorous exercise goes down by 50-fold. So the more that we move, the less risk we're at. And most of what we know about this now is that you are at greater risk of continuing to be sedentary than you are of beginning to move. And that's, again, a big difference in people's paradigm with regards to exercise. People think exercise is bad and it's dangerous and all these things because they hear of the one person who had a heart attack when they started shoveling heavy snow in the first snowfall of the year. However, it is rare. It does not happen often. And so then we have to, the key thing is that if you are not fit enough to do vigorous exercise, guard against it. And I'll explain what vigorous exercise is in a second. The other thing that people present to emergency departments now more and more are mental health issues, for example. And physical activity is a major mediator of mental health. Major mediator. It is as effective, if not more effective, as many of the medications out there. And when we look at the contributors to physical or to mental health issues, physical activity and the lack thereof is one of the strongest predictors of it. And so this one was, again, a very recent study just published in 2019, so January 2019, showing objectively measured physical activity 15 minutes per day in a database of 90,000 people reduces risk of depression by 26% for those with and without major depressive disorder. So didn't matter whichever way. The dose of vigorous activity increases serotonin and dopamine in the brain, which helps to mediate neurotransmitters, which is basically what we're trying to get after there. And now new evidence is showing that each hour of light physical activity per day is associated with about 1 year less brain aging. So in an aging, unfit population, this is a big issue. For those that are inactive, it's even more potent. 1 hour is equivalent to almost 2 years less brain aging. If you're physically inactive, getting active actually is important for your brain. And it's been shown in study after study in mice and humans that the more exercise you do, the more your hippocampus and regions of your brain hypertrophy. They actually grow. Just like if you do weight training, your muscles grow. If you do movement exercises and vigorous exercises, your brain grows. So physical activity and mental health benefits are numerous, whether it's improving sleeping patterns, weight loss, improved life expectancy. There's numerous mental health benefits such as reduced risk of depression, improved mood, all these things. So you as an emergency physician, why should I take my precious time that I have limited in an emergency department for physical activity counseling and prescription? So this was a study that was published this year in Applied Physiology, Nutrition, Metabolism, showing that 73% of emergency physicians believe that the emergency department doesn't allow time for physical activity counseling and prescription. But 80% of you believe that it would be effective. So some of you, it's related to maybe a lack of comfort with the material, and that's partly related to it's not typically covered in medical curriculum. And only 12% prescribe often, and that's pretty typical across whether it's emergency, family medicine, you name it. But brief physical activity counseling and exercise prescription is effective, especially by physicians, and people basically take your word for what you are going to recommend to them. It increases the adherence to physical activity by 50 to 100%. It's cost effective. It produces clinical outcomes. And health promotion and disease prevention are effective in emergency departments. This was a study that was done in smoking. And so if we look at the number needed to treat to address smoking as a health promotion thing, it's 50 to 120. You'd have to talk to 50 to 120 people in order to get one of them to quit smoking, or the same person 10 to 12 times. To get the same health effects or almost equivalent health effects by getting somebody up to guidelines, it would take talking to 12 people or the same person 3 times. So the same person would be more of a primary care approach. For you, it's talking to 12 people. One of them is going to take you up on that advice. And so that's where, when the student is ready, the teacher appears, and maybe we'll come back to that in a second. So the brief counseling can be effective if the opportunity presents itself. And so that's what we're trying to do with Exercise is Medicine, is have more healthcare providers talking about physical activity and exercise because the evidence is there, and then linking them to supports that might do it. So the opportunities in the emergency department are probably pretty limited. So what things can you do? Well, you're probably in maybe the 30-second window, maybe stretching into the 2-minute window there, but you're definitely not in the 10 to 20-minute window, I can tell you that. That's more of a referral for someone else to do. So what can we do in that ask thing? Well, the 5 A's model for physical activity counseling is similar to that which developed for smoking cessation and addictions and these kinds of things. So if we are going to assess, advise, agree, assist, arrange, basically what you might be able to achieve is maybe assess the level of physical activity to help inform you on the fitness and health of your patient in front of you. And it's been shown that if we measure physical activity as a vital sign, it is actually predictive of somebody's health. And if anybody's heard of the Framingham risk factors, that adding physical activity to that model increases prediction by almost 20%, which is an incredible improvement in its sensitivity and specificity. So just asking how much, on average, how many days a week do you do moderate activity like a brisk walk? And on average, how many minutes do you do that? That will give you an idea of whether or not somebody is sedentary, which means they're at higher risk if they have other comorbidities. If they're somewhat active, meaning above 75 minutes a week, that means that they're not at the very fragile risk state. And if they're above 150 minutes, that means that their risk of having cardiovascular disease issues and things like that is much lower. So then the question is, what is moderate activity? And this is one that I get asked a lot. And it's basically light physical activity is anything up to about 3 METs. And 3 METs is basically walking at 100 steps per minute. So I'm going to, I don't know if I have time here. I'm coming up on my time. Yep. Okay. And moderate pace is 100 steps per minute. So anybody know a song that's 100 steps a minute? Staying Alive? So we use that for CPR, right? Which obviously important in the emergency department context. But what we'd like to see is people walking at 100 steps a minute in order to prevent that heart attack from happening in the first place, as opposed to having to resuscitate them. But that's 100 steps per minute would be a moderate pace. And so then you're in this zone. Now, vigorous exercise is a different thing, and that's where we get up to above 6 METs, metabolic equivalents, which would be a very brisk walk where we're getting out of breath potentially. So I'll explain a little bit more detail on that one in a second. So you might have enough time then to advise around the guidelines, and our guidelines basically say you should try and get up to 150 minutes, but Canada is going to be revising and updating its guidelines coming out probably in the fall. And the new evidence basically says any minute of physical activity is a good minute of physical activity. It's optimal to work towards 150 minutes or more, but any minute that you move is a good minute. So if somebody's not doing anything, doing 5 minutes a day is better than that. And that's where you can begin with your counseling. And so we've developed actually a prescription pad for exercise as medicine that you can download, you can order from Canadian Society for Exercise Physiology that could give you the opportunity to do a brief prescription. It outlines what is moderate intensity on the back there, where your heart rate's a little bit more elevated, you're breathing a little bit more deeply. And you could use this to do a brief counseling prescription, because if you do something specific, it's more actionable and it's more likely that people will take that up, as opposed to you should just be more active. That's kind of like, what is that, right? It's kind of like people saying on January 1st, I'm going to eat better. What does that mean, right? So you could circle 4 times a week at moderate intensity for 20 minutes. It's actionable. It gives somebody a certain target to shoot towards. Likewise, on this pad, we actually have their reduced sedentary behavior. Watch less TV may be a prescription. Get 500 more steps per day might be a prescription that is actionable and actually shows that it can relate to outcomes. So the goal there, most people are safe enough to begin at least light to moderate intensity. And so walking like you are late for the bus, that is another good recommendation. So just a little bit of kind of intention to your walking, as opposed to this walking where we're people on their phones. We see this at university a lot, where people take 75 steps a minute because they're on their phones. But if they put their phone away, you can walk at 100 steps per minute. Now, vigorous, if somebody is deconditioned, this is what we want to avoid until they have done some physical activity to cardio protect themselves. And so that's where you want to guard against people getting out of breath while they're doing exercise. So if they're going to shovel the driveway, make sure you take lots of rest break. You don't do, Valsalva maneuvers and those kinds of things. So how am I got just 2 slides left here. And Bruce wanted me to address this one, because this is the biggest misconception that people have about exercise, is that if I'm going to start exercise, I'm going to lose all this weight. And they get it because of shows like this. And that's because these people are exercising 6-7 hours a day. They have dietary coaches, they have psychologists, they have a sports medicine team that's addressing all their injuries and everything like that. They've moved away, they're living on a farm, they don't have family or work commitments or anything like that. So if you want to do that, yes, you can lose 120 pounds in 6 months. But for all the regular people out there, that is a really difficult thing to do. And most of the evidence shows that just exercise alone, after 6 months, you'll lose maybe 1 to 2 kilograms. If that's all you do is exercise and you achieve guidelines, which is great, because you'll reduce your risk of chronic disease quite dramatically. But you won't lose weight probably to the level that you think you will. Now, if you combine that with dietary intervention, you can lose probably 10 kilograms. And actually, your best improvements in fitness are when you both exercise and do a dietary approach, because your relative fitness improves because you lose body weight and you improve your fitness. And so This would result in about a 20% reduction in all-cause mortality if you either reduce or increase exercise, but if you do exercise and diet, it improves your relative fitness by about 40% or 20%. Sorry, that results in a 40% reduction in all-cause mortality. Now, having said that, the number one thing that people do is they put all their eggs in that weight loss basket, and if they don't lose weight after 2 months, then they quit. But this is when it's really important to continue, because you reduce your risk of chronic disease, you reduce waist circumference and visceral fat, which is a big predictor of cardiovascular disease and events, and it sets the stage for weight loss, because once you become moving, you're more likely to be able to move and therefore do more to lose weight and to manage dietary and things like that. So that's my brief snippet of the exercise overview. So my summary is: educate your patients that movement is medicine. Any minute is a good minute of physical activity, and the more you move, the better your health will be. Most patients can begin safely 1 step at a time. So if 5 minutes is what they can achieve, start with 5. If they can do 10, great. If they can get up to 30 minutes, that's wonderful. You can individualize recommendations by just putting it on the map, by asking somebody about physical activity. You may have done your job. And then when they see their family physician and they ask about physical activity, then that keeps the ball rolling and puts it on the map. It's just like if you measure blood pressure, people start to believe that blood pressure is important for their health. If you can get to the point where you give them a personalized recommendation, well, that's really doing a very good job in that context, but I understand that that might not be achievable in many situations. And then making referrals back to their family physician or to other, cardiac rehab or whatever it might be the other area there. So thank you very much. I don't know if we have 1 minute or so for a question right now, and then we'll...
Can we take one question? We're going to have a question period at the end, but if we could take one question, and you had a burning one? Yeah.
Hi. So there's been a ton of data on the effects of exercise on aging diseases like cancer. But out of curiosity, is there any evidence to show its effects on MSK issues?
Oh, yes, for sure. Yeah, so for example, the number, and especially in aging conditions, but low back pain is one that definitely there is a very strong evidence based, and I'm actually speaking on Friday at the Canadian Memorial Chiropractic College on exercise as medicine, and one of the first evidence-based practices, more so than interferential and spinal manipulations and everything like that, exercise is actually the most important thing you can do to maintain low back health, both acutely and chronically. So that's one. But the other one is for older adults doing muscle strengthening and balance. The number needed to treat to prevent 1 serious fall is 11. So if you have 11 older adults doing muscle strengthening and balance activities, you will prevent 1 serious fall in those 11 people, which is huge. If you think of the cost implications of falls in the older population, and you have 11 people exercising, and like I said there, with the number needed to treat on counseling, it's 12. So if you talk to 12 people, one of them is going to get going. So, you mentioned doing some muscle and bone strengthening exercise for 100 people, you've prevented 1 serious fall. Yes.
Thanks very much, John.
Thank you.
So thanks. Yeah, I'm going to do 2 very quick talks here, and I'll pick up on the dietary thing here. So it was about 3 years ago. We were vacationing with a cardiology friend in Hawaii, and he was reading voraciously around this bit about low carb, high-fat diets. And he got me involved in this, and as I was developing that little bit of a middle-age spread here, and he was realizing that he's been counseling people on diet for his last 30 years of his career. And it had this. So the high-carb diet put you on 20 years ago, gave you diabetes, high blood pressure, and heart disease. Oops. He's now totally revamping what he's practicing when he teaches. He's just like me, trying to eat that low carb. And this is the other thing that convinced me, aside from him, was this read here called The Big Fat Surprise by Nina Treikoltz. Absolute page turner for me. Read it twice. Gives the science of why we think fat is so bad, why we've been counseling people for all this time against fat, when really the evidence was not there, and how it happened, coming down to personalities and really bad science.